Okay. Yes, my presentation today is about complex lesion PCI, and I focus in a very calcified lab intervention. Very calcified lab intervention is often complex PCI. And I'll remind quickly about what complex PCI according to the definition of the 2020 SKY. We have at least three factors. The first factor related to anatomy. It means difficult anatomy, multivessel disease, calcified lesion, lab-man bifurcation, instant restenosis, look like the presentation of Dr. Pinto. CTO, self-inert vein graft disease. And the second is the comorbidity of the patient. Look like heart failure, acute coronary syndrome. It will make the patient become very easy, unstable, and maybe hemodynamics, the compromise. And the last about we must have the support from the instrument device, such as the atherectomy, such as cover stand, such as IVI, so on. And the evil rarely go along. Complex PCI would be more complex when there are a combination of many phenotypes of complex characteristics. So my presentation, I like to talk about us. And my topic is a very calcified lesion. So we talk quickly about characteristics of left-man PCI. Why left-man PCI is complex PCI? Because the left-man trunk is very special anatomy of coronary artery disease. It supplies blood for whole left heart. And as we know, just only 40% of compromise, it can induce cardiogenic shock. It's the largest bifurcation with not small side branch circumference. It have a strong recoil elastic strong power, and it have a large vessel diameter. It's very mid-match between the left man and LED and circumflex. And in the left man disease, sometimes we have a CTO of the right coronary artery disease. So it becomes the last remaining vessel PCI. As you know, the last remaining vessel PCI is very dangerous. It's very easy to fall into the cardiogenic shock because we do the last remaining vessel supply blood for almost whole the heart. And we talk about characteristic of repeat revascularization. I don't talk about that because Dr. Thượng Pinto have talked very clearly. But I have one case for left-man PCI in combination with instant restenosis. And one more, the calcified lesion. In the very calcified lesion is very challenging. To get successful PCI in the patient with coronary calcified lesion, request many advanced procedure, training, and skill. I think everyone know about the strategy technical problem when we do the calcified lesion. Even without significant lesion, may be difficult to deliver the equipment distally, and at high risk for stent stripping, very difficult to cross lesion with wire, and possible to wire, but not crossable with device. I have some kind after. And we not possible to fully extend stent or stent regret. And we need necessary technique and instrument such as the rotablator. And because it's the many obstacles, so the patient after calcified lesion PCI often have a worse outcome. Both PCI myocardial infarction, restenosis, sarcophagus lesion, revascularization, dissection, rupture, perforation. And I have some guide for demonstration and for for us to discuss or to us to receive some advice from expert. The first case is the left-main bifurcation disease in combination with repeat revascularization. In this case, instant restenosis type 3. The patient who do the PCI stenting at the 3 times, 2015, 2016, 2018 with the 5 stent and 3 DAS and 2 BVS. And the patient very severe COPD type D. And recently, they develop frequency dyspnea, sometimes Japan. And this is the coronary angiogram. It's in the right side. We can see a severe long diffuse lesion along the proximal, mid-segment, and the distal segment. And when I see about the history of PCI, look like in the RCA, the patient were deployed to PVS. And about the lab, we can see the first stenosis distal left main and involve pole of ostium of LD and circumflex. And we can see the one stent from ostium to proximal segment of LAD have instant restenosis. You can see in here very clearly. A stent covered from ostium to proximal segment of LAD. And we have it in combination with the distal left main disease, involve pole of ostium of LD and circumflex. And plan to do PCI with strategy. The patient have an instant restenosis of the LAD and RCA, so I think we must use IVI to assess which type of instant restenosis to choose a suitable treatment. The second, distal left main disease involve pole of ostium of LD and circumflex in combination with instant restenosis of LD and look like heavily calcified distal left main. So we must select, we must choose intentional two-stent technique, maybe stent of LAD also for treatment of instant restenosis of LD. With two-stent technique, I think a TK cross or TAB is suitable. I have a lot of iVert clip, but my clip look like wrong. So today, when I insert the clip of the iVert, it made my laptop stop. So I have only some one. For the LED from inside to outside. Then the reverse stand. This toe stand is good, but we can see type 1 and type 2 under expansion in combination with neo plug and very neo calcified. The lesion from mid-stent to the ostium. Very severe stenosis of ostium of LAD. A little bit stent protrude to the left main. This is from circumflex. The circumflex look like very good, except the ostium and the mid of circumflex, the mid calcified. proximal, and now ostium very severe. So I drew distal bifurcation development. And according to Wassmann classification of extended stenosis, this case belongs to type 3 mixed pattern combined mechanical and biological etiology. And how we can treat this is for the right. I am not focused the right because it's not enough the time. In the right, the stenosis, but with the PGS, so by now we don't see the structure of the stent go for the long time, and we must use a scoring balloon, cutting balloon to prepare plug modification and stenting. And the last result, you can see between two stents have a look like stenosis segment, but when I use invert, the stenosis only 30%. So I don't like to the full metal jet kit and I leave it alone. About the lab, the first I use the cutting balloon, a scoring balloon to prepare for instant stenosis. And I prepare a stenting for the bifurcation of the distal ligament. And when I see in the IVUS, the distal segment of stent is okay, no restenosis and no under expansion. So I choose the technique, the two stent with the one stent in the ostium and proximal segment of circumflex and one stent from labment to proximal segment of LD. Fixing, and we stand in the circumflex, and we prepare a stenting labment to LD proximal segment. That is the last result. We do optical, we do the final kissing balloon. And we have a recall the IVUS not the IVUS catheter not go distal, but in the mid segment of the stent. But the result is very good, but the file not good, so I cannot show here. It large result, right, choreography. Okay, so the first case I like to show the evil or rarely go along. It means one case with instant stenosis in combination with labment distal bifurcation lesion with the two stent technique. And the second case, I talk about labment bifurcation disease in combination with very calcified tortuous diffuse. We call the rosary bit. Oh, sorry, bit D, not T. This is the left coronary artery. We can see labment heavy calcified lesion, distal labment involved to the both ostium and proximal of LD and circumflex. And long diffuse lesion along the LD. In the left, very calcified proximal and mid segment of RCA. And so detail when I do PCI in the RCA, but in the RCA, after we do IVUS, I must use rotablator because the calcified burden very heavy. And after I use rotablator in combination with the cutting balloon, I deploy stent, it's okay. I focus in the lab, as you see in the lab, very severe and diffuse, and talk to us of the LED. First, when I do wiring, very difficult because it's a talk to us. It gets stuck because plug calcified burden very large. Because as you see, you can see, as you see, the LED very diffuse and the total region can we yield the bulb. I think if we don't yield total later, we cannot advance the stand, but with the risk for the rupture of perforation, so I must choose the smallest rotable 1.27. And it goes smooth with the high speed, about 180 to 190 rounds per minute. After we do a rotable successful, we do a pre-dilatation. And with the support of either Zella extension or guided catheter, we can put the stand for the mid segment of the LED, and the second stand covered from left main to proximal segment. What's the rotation? So the last result, I think it's okay. I don't touch the circumflex. It's very complicated. So before PCI, after PCI, before PCI, after PCI, I think the result is good. And the last case I like to present for you, and I like to ask your advice and your opinion. In this case, a very, I think, very specific. One case with the left main bifurcation disease in combination with the very calcified long diffuse disease. But I have a plan to do calcified plug depoking of the proximal segment of LAID, but something happened, and I must deploy stand to the left main. So how I can do continuous? Here, coronary angiogram. We see very severe calcified lesion in the distal left main and the proximal segment of LAD. The circumflex not large. So I like to select one stand technique, but I must do a preparation very well of the distal left main and proximal segment of LAD. In the coronary angiogram, when I look for the left main and ostial left main, look like not clearly, look like not severe stenosis. I think some plaque here in ostium of the left main, but I don't pay attention very much to the ostium of left main. But some view have the lesion of the ostium of the left main. And based on CTO of the right coronary artery, so it become less remaining vessel for we do the PCI. Of course, we have a balloon pump in advance. So this is my plan to do a PCI calcification with large burden along distal left main, ostium proximal mid LAD. So we try to choose rotor in combination with the cutting balloon or scoring balloon. Stenosis severe calcified distal left main involve pole of ostium of LAD and circumflex. We choose, of course, two stent technique is very good, but it might take a lot of time to do that. And it's very dangerous because this is the last remaining vessel. So I choose one stent provisional side branch technique. Of course, because it's the last remaining vessel, I have a standby for the bump. Here we can see the first, the wiring very difficult because of very severe calcified in the proximal segment. As you see, and the tip of the wire go to the most severe stenosis calcified. And you can see when I push the small balloon 0.8 and 10 millimeter, very smallest balloon I have, it gets stuck in the severe lesion. And you can see the tip of the guiding catheter, some in, some out, some in, some out. When I put it jump out, when I put back the balloon, it jump in. You see? And because the ostium of the left main have a lesion already, so the patient become terrible, hypotension, chest pain, dyspnea. So when I check again, something wrong in the left main, ostium left main, I must deploy stenting of the left main immediately, slow flow into all the left main in the patient with the left remaining vessel. Very quickly, stenting from ostium cover the left main. Okay. After I deploy the stent, cover the left main, everything's okay, becomes stable. So by now, what can I do? Continue that. Unintentional stenting of the left main, very new fresh stent of the left main. How can we use rotor-ablator? Or we just use the balloon, cutting balloon, but the smallest balloon, 0.8 by 10 millimeter, it's very difficult to get out, to go through. So how we can use cutting? So what we do now, and I like to hear some, have a short discussion. I like to hear some opinion from experts. Maybe Dr. Pinto.
So just to confirm this scenario is that we have underexpanded stent in the left main that needed to be placed because the patient got sick with a lesion. And the question is how do we expand it further now? Is that correct?
Yeah. How we continue to do for the lesion in the proximal segment of LAD, very severe stenosis here, very calcified.
Yeah, so, I would continue with a probably 15 millimeter cutting balloon, trying to get that calcified lesion in the prox LAD open. I would, do some intravascular imaging to see whether it's working or not. I wouldn't worry about perfection in the left main as long as the area was good enough based on the intravascular IVUS. I think you've already been through a lot. The patient has been through a lot. I think at this point, it's to try to get a stable and good result in the prox LAD. And then we can let the patient recover if we want to optimize further later. But as long as you have a good result in the left main, as far as area, I think you're good. I think you're happy.
Yeah, thank you. Because the smallest 0.8 by 10 millimeter cannot go through, cannot pass the lesion. So I think cutting balloon is bigger. And by now we cannot use the IVI because I think the IVERT or catheter of the OCT cannot go through. So
I think I would just dilate there. If you're having delivery problems, I personally would use guideliner, guide extension to try to deliver if I thought it was a backup problem. But I think just balloon, and try to get it open,
Yeah. Thank you so much, Dr. Gilberto. Maybe one opinion from other panelists from Vietnam. Dr. Ngô Minh Hùng.
Yes, a very complicated case, really. So actually we is out of our plan as we said before we do the procedure. So now we have to say the patient's life first, as you did that in order to stabilize the patient. So now you're asking about the what we call that, the proximal LED very calcified lesion behind the stent. So in this situation, as Dr. Pinto already mentioned, that you use the smaller balloon or multiple ballooning. That's the safer option. But in this situation, if we cannot open the LED to get a little bit better flow for the distal myocardium. So if we cannot do that, so we have to use the smaller burr in order to rotate the proximal LED. Of course, we have to use the for example, STO1 or support catheter in order to pass through the stenting segment, and then we do the stenting. But this is very risky for the patient because this is the last remaining vessel. I don't know you did the case with that which kind of option. Thank you very much.
Okay, thank you. I do the same your suggestion. Because the first I like to try rotator so much at each and Y. But when I do each and Y, we cannot do each and Y with the microcatheter because the microcatheter cannot go through the very stenotic lesion in the curve. So I must go the microcatheter to the lesion, and after that we go directly rotor Y go to the distal. But the rotor Y cannot go to distal. It gets stuck. Is this the position of the rotor Y in the distal part of the mid segment? And we try to do a rotor plater with the smallest burr is the 1.75. But we try to I don't have to have the microcatheter for suitable for the burr. So I try to manually bring the burr over the stent, go to the proximal segment of the left man. Very difficult. But you see, the burr always like to go out, not come in.
I see that you have a balloon, or a wire in the circumflex.
Yeah, a wire in circumflex for backup, not another reason.
Yeah, I wonder how big is the guide?
The guide is 7 French.
Yeah, I wonder if you could anchor a balloon in the circumflex and try to pull the guide in farther and maybe help deliver, because it looks like it's a guide support problem.
Yeah, good idea. And finally, I can bring the burr over the stent in the left man and into the ostium of the LE. And can you see 1, 2, 3, 4 cannot pass. One more, 2, and in the third. Yeah, in the third successfully.
It's a 1.25 burr or
1.25. Yeah, 1.25. Only one burr.
Yeah.
And after the burr go cross the lesion, the Y go distal easily because it gets stuck in the severe stenosis, and everything become easier. And after we burr, we yield IVUS. This from it gets stuck in the stenosis lesion after the burr. It comes from inside to outside, so you can see the stent. And the second goes from outside to inside. It gets stuck here. And the third IVUS is the last result of IVUS, but the file not good. So it's wrong. So I continue to do in the angiogram. You can see small balloon, pre-dilatation, cutting balloon, and we use extend guide to bring the distal stent to the mid, cover the severe stenosis. And the second stent cover from left main to cover the proximal segment of LDD. And the final result.
Nice. The circumflex looks good too.
Yeah, lucky. Okay, I think the last result is good. So takeaway message, a very calcified lesion left main intervention, really complex PCI. Interventionist need a good plan before to do. We need the IVI, plug modification or plug defocking. We should have some request ability interpretation of the IVI, manipulation of device for plug modification, defocking, balloon rotator. We should be familiar with the two-strand technique, and we should have a mechanical circulatory support nearby. We must do with a good team and teamwork. Young cardiac interventionists gradually encounter unintentional, difficult, or dilemma situation. We must learn how to solve them. We should have a good plan before to do complex PCI, and we should predict some difficulties, some obstacles to overcome. Sometimes procedure get out of our plan, even the best one, look like my case. Keep your calm, ask senior advice. In most of cases, they often have some solution. In last resort, ask senior health or heart surgeon help. To do the complex PCI, we must learn to solve difficult or complication. Okay, thank you so much for your listening.
Thank you very much, Professor Hồ Thượng Dũng, for sharing us the three interesting cases, especially the third one, when patients presented with very heavy calcified lesions in left main LAD, torsus also, and it can be considered as the one remaining vessel for the heart. So I believe that you are a very strong man, a very brave man to choose a PCI as a revascularization method for this patient, because in my own opinions, bypass can be considered as the first option of that patients. So because of the limitations of times, I just have a very quick question to all the panelists. So in case of last main vessel for the heart, is there an options of an upfront IBP or upfront impeller for the colleagues in US to do the case to make it safer? So we want to hear from Dr. Pinto and also my good friend, Dr. Kumar. He's now online now. So please have your opinion sharing if we have MTS upfront before a very, very high risk procedure.
Yeah, it's a really important question. I think a question that is a lot of controversy, and we don't know the truth. We have a luxurious situation in the United States that we can use it if we deem necessary. I'm interested in the ongoing trial Protect 4 that's randomizing patients with very complex disease and reduced ejection fraction against Impella versus either nothing or balloon pump. There are certain cases that I've not been able to do were it not for an Impella, that the patient was non-pulsatile for most of the case, and they got very sick. They would have been with a blood pressure of 60 for an hour or two. And I've also had patients who died on the table from hemodynamic embarrassment after during the PCI because we couldn't support them effectively. That doesn't mean that we have to do mechanical support in every case where it's complex. And I tend to not use it simply because someone has a reduced ejection fraction and complex anatomy. They have to have some evidence that either they are in heart failure, elevated filling pressures, and or reduced cardiac output. And then if I'm going to rotablade a very extensive area, and like in this case, the anterior wall, I will be more free about using an Impella. So I don't know what the ejection fraction was in this case or whether the patient was compensated before, but you can see the extreme stress on the patient and the operators that happened when the patient's left main dissected. And that, would be a very stable situation with an Impella in, and you would have more time to think and to deal with the problem. Now, obviously, this case turned out great, but I don't know that every single one and every single operator in this case would be able to accomplish what was accomplished here. So it's a long answer. I didn't give you an answer, but it depends, and I await the results. Again, I think for practical reasons, most of the world is still going to have to do the cases the way that they do it, because I don't think a $25,000 device is going to be practical for most cases.
Thank you, Dr. Pinto. So, Dr. Kumar, any idea about MCS for that kind of PCI?
Thank you. This is a very complex lesion. And without really knowing what the ejection fraction is, I am assuming it is possibly low. And given that, and the extensive atherectomy that is required in the left main, well, in the proximal LAD and distal left main, ostial, I would say left main bifurcation, I think I would have erred in favor of mechanical circulatory support in this case, but then again, that is with the power of hindsight. I recognize the fact that this is a $25,000 device, and this is not something that is available. Now, even if we can say we're going to take the cost of this device and put that to the side, and we are not going to, in a dream world for a second, if you follow me and say, okay, we are going to be in a dream world. Even in a dream world where cost is, let's say, not really an issue, the access complications from the Impella, the vascular, whether the iliacs are adequate, access site complications, all of these issues also add on. And so, we need to consider that as well. And, a lot of these considerations need to go into play in terms of some of these cases. So yeah, it is not easy. And it's, I think I would have erred in favor of having a mechanical circulatory support device. But again, I can understand it can go either way in these kind of cases.
Thank you, Dr. Kumar. So even in our dream world, we still have problem. Okay. Okay, so let's move on because of the limitations of time. So I want to introduce my close friend, a famous operator in not only in US, but also in Asian area. So Dr. Gautam Kumar, he will talk about optimal PCI and complex PCI.